On behalf of United States, I would like to welcome you for another exciting session today. This is my distinct honor and pleasure to introduce you Professor Gadi Lalazar, who is the Director of Hepatology and Deputy Chief of Gastroenterology at Shaare Zedek Medical Center in Jerusalem. He's a senior hepatologist with over 20 years of experience in academic medicine, clinical care, and translational liver research. Dr. Lalazar received his medical degree from the Hebrew University of Jerusalem and completed his training in internal medicine and gastroenterology, hepatology at the Hadassah Hebrew University Medical Center, where he also served as a representative to the National Transplant Committee. He subsequently completed advanced research training in clinical scholar at the Rockefeller University, New York, in the laboratory of Drs. Sanford Simon, where he developed novel mouse models and investigated mechanisms of resistance and therapeutic strategies in liver cancer. He has held faculty appointments at the Weill Cornell Medical College and the Rockefeller University, and has been actively involved in international guideline development for metabolic-associated steatotic liver disease. Over the past 4 years, Dr. Lalazar has led the Hepatology Unit at the Shaare Zedek, establishing a dedicated clinical trials program and a multidisciplinary hepatocellular carcinoma service in collaboration with GI Oncology. Dr. Lalazar is a member of the Israeli, European, and the American Association for the Study of Liver, and currently serves as the chair of the Hepatocellular Carcinoma Special Interest Group of the Israeli Association for the Study of Liver. With that introduction, I would like to welcome again all of you and hand it over to Dr. Lalazar, who's going to talk today, evolving strategies in the management of intermediate stage HCC. Over to you, Dr. Lalazar.
Thank you very much, Professor Sarapati, for this kind invitation and kind introduction. And I'm looking forward to speaking to all of you about intermediate stage HCC, a complex condition that we all grapple with in our clinics. HCC is the most common primary liver cancer, as we all know. It is the sixth cancer based on incidence, sixth most common, with the third most common mortality. And if we look at the prevalence, the incidence and the mortality across the world, we see that the map is very uneven. And we also notice a disturbing fact that the incidence and mortality from this disease are very similar, 3 to 15 out of 100,000 and 3 to 12 out of 100,000. So many patients with this disease will die of liver cancer and the complications of cirrhosis. And the future doesn't look bright. There seems to be a prediction that by 2040, there's going to be a 60% increase in the number of cases. So this is clearly a disease that we need to grapple with. Now, the other problem is that the 5-year survival of HCC, despite some improvements in the past 2 decades, is still about 22% in the US and is lower than 20% across the world. In fact, it's one of the only cancers with such a low 5-year survival rate. And this is tightly linked to the stage of diagnosis and hence the efforts across the world for surveillance and early detection of HCC. And the leading and most widely accepted staging system for hepatocellular carcinoma is the Barcelona Clinic liver cancer staging system. It's been the #1 used and endorsed staging system across the world, definitely in the Western world, for the past 20 years or so. And it is based both on prognosis and therapy, which are derived from the stage. And what differs it from other cancer staging systems is that apart from the increasing tumor burden, which is common to other cancers, there's also the decrease in liver function as we advance in stage, and the performance status. And all of these will dictate both prognosis and therapeutic decision. Now, this audience is clearly familiar with the child score, but I want to also highlight another score which we use in HCC, which is called the ALBI grade, and it's based on albumin and bilirubin. And as opposed to the child score, it is a continuous score, as you can see the formula right here, dividing patients into 3 ALBI grades. And if we look at the continuum of compensated to decompensated liver disease, we can see that the ALBI score is especially useful in the more compensated patients. And this is very relevant to therapeutic selection in HCC. And now these stages, as we said, are prognostic, and they also entail different therapeutic goals. So in the early stages, 0 and A, our therapy is with curative intent. In the mid stages, the intermediate stage and advanced stage, B and C, we'd like to control disease and hopefully downstage it. And finally, in stage D, the therapeutic goal is mainly palliative. And today we'll focus on BCLC-B, or the intermediate stage. And to summarize what the stage really encompasses, these are patients that are beyond the usual Milan criteria for transplant, but really have no portal vein involvement and no extrahepatic spread. And in fact, based on BCLC, any degree of portal vein thrombosis already puts you in the advanced stage, and I'll talk about this more in upcoming slides. So as you can see, though this is one stage, it's a pretty heterogeneous stage, and patients are quite different from one another. And if we start over here on the left, we have patients who fit extended criteria for transplant. There are patients with well-defined nodules, and there are patients with more diffuse, perhaps bilobar involvement, so a larger tumor burden. For the patients on the left, if possible, they'll go to transplant based on extended criteria. The patients in the middle, the frontline therapy for them is TACE. And on the right, they'll go for systemic therapy. But the line where we go from local regional, i.e. TACE, to systemic therapy is one that's open to debate. And to make things more complicated, we can think about combining therapy, both TACE and systemic therapy. So what's the role of combination therapy? We'll talk about that. And there's also a two-way street between TACE and systemic therapy, and whether we choose TACE as our first line, and then the disease becomes, quote unquote, untaceable, or we have treatment failure, we might progress to systemic therapy. And conversely, if we have some response to systemic therapy, but a non-responding nodule, we might add TACE. And under the best conditions, when we've successfully downstaged, then both of these groups might then be downstaged to transplant criteria. So there's quite a lot of movement within this diverse group of patients. And just to make this real, here's a patient we had in clinic, a 78-year-old female with valvular heart disease, HCV cirrhosis. She was treated with SVR, and on imaging, she had a 2-centimeter lesion treated with radiation because of a critical location, proximity to major vessels, difficulty resecting it, and patient preference, and she had a partial response. But on follow-up imaging, she had quite a few nodules, about at least 4 nodules, and here are the measurements. She had some mild ascites now, and you can see her portal vein was patent. These are her labs, and her alpha-fetoproteins summarized here: child A, ALB2, and ECOG1, and here are her hyper-enhancing lesions. And the question is to the audience, what would you do with this patient? And you can each choose for yourself. Would you TACE, TARE, give systemic therapy, combination therapy, interest in a clinical trial, or just because of age, comorbidities, and the stage of the disease, offer best supportive care? So what are the open questions in the treatment of the intermediate stage of HCC? So first of all, which criteria can help us in this decision, like in that patient, between local regional and systemic therapy? When do we combine therapies? How do we deal with portal vein thrombosis? And then what is the role of TARE versus TACE in this intermediate stage? And I'll try to address all of these. So back to our patient, she has some pretty well-defined nodules. She has 4 of them. The question is always, why not just start with TACE? And if we fail, then we could always progress to systemic therapy. And that's a very relevant question. And the answer really lies in toxicity. And the data shows that for each TACE session, roughly a 5th or a 6th of our patients will experience some form of decompensation. And this then impairs the prognosis of subsequent systemic therapy. And this is a post hoc analysis of the IMbrave 150 data, where just based on the ALB grade 1 versus 2, you can see that we completely lose the advantage of systemic therapy. So this actually seems to be quite important. And preservation of liver function is an important issue to remember when we sequence intraarterial and systemic therapy. The other issue is that size and number of tumors are prognostic in patients treated with HCC. And there were quite a few studies about a decade ago that showed that both the size and the number of tumors were indicative of prognosis. And that brought back the up to 7 criteria, which means that you look at the number of tumors plus the size of the largest tumor, and you parse the patients based on whether it's under 7 or over 7. And this was not a new invention. This was first proposed by Massafero and the Metro Ticket Group as a criteria for liver transplant beyond Milan. And now this was adopted for HCC. And we have some follow-up studies that looked at this retrospectively and showed that this is an Austrian patients. There was an increase in the overall survival with TACE based on within or beyond up to 7. This is complete response with TACE. In Korean patients, you can see the drop between within and beyond up to 7 from 59% to 14%. And finally, there was this Japanese cohort from Kudo's group where they compared TACE versus an lenvatinib, and you can see the change in the overall survival. And this was in 90 patients that had tumors beyond the up to 7 criteria. And it seemed like the patients on systemic therapy did much better here, but this is all retrospective data. And what do the guidelines say here? This is from the most recent guidelines, the EASL guidelines, and they say that we should really be using local regional therapy when a selective approach is possible, but this should be based on low tumor size and number, i.e. within the up to 7 criteria. What about additional criteria beyond tumor burden? And the answer here is that it's a bit confusing, but the answer is no. So while tumor burden is very useful, as I illustrated, the other prognostic scores are not so much, and that is because they weren't tested for this question of local regional versus systemic therapy. All of these listed below can actually help us determine the chances of success for each type of therapy, but they don't really help us choose and shouldn't be used that way. Another question is, do different types of TACE matter? And the answer essentially is no. They're pretty much considered equal. DEB-TACE and C-TACE are equal, and TAE bland embolization is considered an alternative. And here, since we only have retrospective data, are 2 trials that are now trying to test this prospectively. And this is the ABC-HCC trial, a phase 3 trial looking at atezo-bev versus TACE. And this allowed VP1, VP2 portal vein tumor thrombus. So this was patients that had intermediate stage HCC, not amenable to curative surgery, and they were compared with atezo-bev versus TACE, and the primary endpoint was time to treatment failure. We can see here that quite a few, the majority of these patients had some vascular invasion, VP1 or VP2. And this was a positive study based on that endpoint, and we can see the advantage for the atezo-bev arm versus the TACE arm, but the overall survival data is still immature. Another study that's testing our direct question is specifically in patients with tumors that are beyond up to 7 in the intermediate stage. And here, portal vein tumor thrombus was not allowed. So this is a strictly by the BCLC criteria type of trial. And here we're comparing regorafenib and pembro versus TACE or TARE. So this will be an interesting study to see. It's currently recruiting, so we don't have data yet. And what about combination for these patients? The idea of combination therapy is actually very alluring because when we administer local regional therapy, we can potentially change a non-inflamed tumor into an inflamed tumor with a more immunosupportive microenvironment by the immunogenic necrosis of tumor cells and the release of tumor neoantigens and pro-inflammatory cytokines. Another interesting note is that the ischemia created by local regional therapies will induce VEGF, and this is why the combination of TKIs and anti-VEGF antibodies such as bevacizumab are commonly used in these combination trials. The only problem was that for a whole decade, this didn't work. TACE plus TKIs, there's a whole host of studies, many of them negative. Some of them showed improvement in progression-free survival, but none showed improvement in overall survival. And the price of incorporating TKIs here was, of course, increased toxicity. So there was a price to this. And that's why this is quite an active area of clinical trials. And these are combination TACE therapies that are ongoing. And this has even been moved into the advanced stage now, comparing the addition of TACE to atezo-bev. And the first trial I'll talk about is the EMERALD-1. And this is a study, again, in unresectable non-metastatic HCC. And VP1, VP2 was allowed, minimal tumor thrombus in the portal vein. And it compared TACE plus durva plus bevacizumab to TACE plus durva and TACE alone with placebo. And the primary outcome measure here was progression-free survival, and we can see that was positive for the addition of both durva and bevacizumab to TACE versus just placebo in TACE. And there was no advantage to durva alone. So this is an improved PFS, but the overall survival results are only expected to read out later this year. In this study, we can see, based on the subgroup analysis, that the advantage was in patients with excellent functional and liver function status and a larger burden of disease. The second study was the LEAP-012, and here lenvatinib and pembro compared with TACE compared to placebo in TACE. No vascular invasion was allowed in this case. And we can see that the primary outcome measure, progression-free survival, again, was positive. So there was a lot of excitement that this was going to be a positive study. Unfortunately, when it came to the overall survival, then this was negative, and the trial was halted at the end of 2025. Interestingly, again, the patients that did benefit were those with excellent liver function, functional status, and a higher tumor burden, so similar to the EMERALD-1 study. Finally, the TALENT-TACE study, and this is comparing TACE plus atezo-bev to TACE alone. And here, a different primary endpoint, the TACE PFS, and with the overall survival as a second outcome. PVTT, VP1, VP2 was allowed. And this is, again, interesting for our discussion because this is a higher, all patients here had a higher tumor burden, in this case, above 6. And we can see that this trial, achieved both the primary endpoint, the TACE PFS, and the standard PFS based on RECIST. And the OS is thus far immature, so we're waiting for the results of this study. So just to summarize, we have 3 randomized trials comparing the addition of systemic therapy to TACE, varying primary endpoints, but all of them showing an advantage in PFS. The LEAP-012, unfortunately, the S was non-significant, and the others are either non-available or yet immature. Again, the EASL guidelines, when referring to combination therapies, they say for TKIs, then should not be combined, and that there is insufficient evidence to suggest combining TACE or TARE with immune therapy. Now, switching gears a little, what about TARE versus TACE? And when looking at the literature, this really seems East versus West type of situation. The main positive data we have is from retrospective studies. And here we have an improvement in the overall response rate, an improvement in the time to progression, but no real survival benefit. And perhaps the most prominent of these studies was the Legacy study. And this was a retrospective study, but it had a blinded review. And it was for single tumors. And in fact, most of the tumors were quite small for patients with excellent performance and liver function. And it showed, and this was a single arm study, so we just have results for the intervention arm, and it showed a very good overall response rate, duration of response, 3rd-year survival, and even conversion therapy to curative treatments. And this is based on the Legacy study. TARE was approved for this indication of solitary and resectable HCC under 8 centimeters. We've had one randomized study. This is the TRACE study comparing Y90 to DEB-TACE. And this was actually a positive study, even for the overall survival. It wasn't a very large study, as these trials tend to be. And the criticism or the difference in understanding the study lies in the fact that there were 3 deaths, early deaths in the TACE arm. And the overall survival for the TACE arm was very low, almost identical to the natural history of the disease with best supportive care. So there's some questions about the validity of these results. There was another small single-center randomized study which showed advantage in time to progression, but no change with regards to overall survival. But you can see that the majority of the patients here were actually BCLC stage A. And this is the largest meta-analysis of TARE versus TACE in the intermediate stage. And we can see that 2,465 patients, 311 had individual patient data. And it showed an improvement again in the time to progression, but no difference in the overall survival. And you can see the forest plot down here reaching across the 1. So finally, if we do consider TARE, There are pros and cons. When should we do it? Of course, if we have portal vein thrombosis beyond VP2, then TACE is contraindicated, so that would be an indication for TARE. Patients that fit the legacy study would benefit. There are advantages when we're downstaging and bridging to transplant, and especially in patients with preserved liver functions, as we saw from the studies, are excellent candidates for TARE. The cons have to do with technical issues, the lung shunt, arterial anatomy. It's contraindicated when there's a VP4 involvement of the main trunk of the portal vein, and of course, when there's a decreased liver function. And if we do choose to use TARE, it is probably very important to use personalized dosimetry. And this is the Dosisphere 01 trial showing the improvement in OS between personalized and standard dosimetry, whether they analyze it based on treatment group or the actual radiation dose delivered. Personalized dosimetry is probably the way to go. So what do the guidelines say about this? And again, this is the EASL guidelines, the most recent, and they say that for the intermediate stage, CERT can be recommended as an alternative to systemic therapy if patients are not fit for TACE or surgery. And again, here for advanced stage, do not use CERT, but rather go for systemic therapy. But if we look at the different guidelines, then we can see that while there's quite some agreement regarding the use of TACE and TARE for single lesions, once we get into the alternative to TACE, there is a clear east to west gradient going here, where in EASL, there's a very weak recommendation only if patients are unable to be treated with systemic therapy, and it gets stronger as you go towards the AASLD guidelines, when TARE is definitely a good alternative option and perhaps a first option for some patients. And with regards to systemic therapy, where here it's pretty clear that there's a recommendation against, except for the ESMO guidelines that say can be considered for the Pembro-Lenva combination, but they're the only ones. And now, how do we deal with portal vein thrombosis? From these trials that I talked about, we saw that the inclusion of VP1 and VP2 in TACE trials was actually allowed. And this is not a small problem, because in different series, between 10 and up to 50% of our HCC patients have some degree of portal vein tumor thrombus. So how does that affect our therapeutic choices? Now, just to reiterate again, by the BCLC, according to the BCLC staging system, the moment you have any involvement of the portal vein, you are in the advanced stage and you should go for systemic therapy. So first, some definitions. This is the Japanese VP classification. So VP0, no thrombus. And then as we progress from subsegmental to segmental lobar, and then main portal vein or contralateral lobar portal vein, we go from VP0 to VP4. And this has a dramatic effect on the prognosis of our patients with HCC. And this is a study, a single center study from Mainz, a large cohort. 40% of these patients had portal vein tumor thrombus, and we can see the dramatic decline in prognosis if we look at no versus any tumor thrombus. But we can also see that there's quite a gradient within the patients with portal vein thrombosis, depending on the degree. Importantly, these are patients that don't do well, and this is again post hoc analysis and later publication on the IM Brave 150 overall survival data. This is the only trial that allowed patients with VP4 to be included, and we can see that while patients without VP4 have a survival benefit, the survival benefit is quite small once we get into the patients with VP4, and the overall prognosis, whether you're treated with Tezobev or sorafenib, is dramatically lower than those without VP4. And this brings us to another interesting issue, which is what is the adherence to the BCLC staging system? Are people actually treating patients based on this system? And we can see here that while the overall adherence, when the 2022 update went into effect, rose to upwards of 70% for the earlier stages, we can see that in BCLC-B and BCLC-C, it's quite low. And we can also see that specifically in these stages, there's quite a bit of upward stage migration. And what that means is that while a patient is in a certain stage, we'll treat them with treatment choices that are reserved for earlier stages of the disease. So this is called an upward migration. And what's really fascinating to see is that in those patients where there was an upward migration of therapy, they had a clearly improved survival benefit, both for BCLC and BCLC. So this is a study from the West, so to speak. What about the East? Here it's even more dramatic, and we can see that the adherence to BCLC is even lower, 50 and 20+%. And again, when there's an upward migration of the treatment, we can see improved overall survival. And some of this has to do with the treatment of portal vein thrombosis. And if we look at it, if we look down here at this review on how we treat portal vein tumor thrombus in the West, based on the BCLC criteria, the moment we have any involvement of the portal vein, we should be transferring to systemic therapy. We see that in Japan, it's slightly more nuanced, where they will differentiate VP1, VP2, and VP3, VP4. We saw that reflected in the clinical trials, most of which allowed VP1 and VP2 to be TACed. And in China, we can see that there's a highly nuanced approach to this portal vein thrombosis, employing both TACE, HIAC, intraarterial chemotherapy, and radiotherapy together with systemic therapy, and also allowing resection at more advanced stages. So clearly a difference in the approach between East and West. And indeed, the results of retrospective data, so these are 4 studies with a retrospective and propensity score matching, comparing either combination, adding immune checkpoint inhibitors, or systemic therapy versus the hepatic intraarterial therapy alone, all show dramatically higher overall response rates and improvements in overall survival and progression-free survival. These are all retrospective studies. There are 2 meta-analyses showing advantage for what's called triple combination therapy, HIAC, radiation therapy, or TACE, plus targeted therapy, plus immune checkpoint inhibitors. We can see an advantage for all of those, both in OS and PFS, albeit with a higher grade of toxicity. We can see in this meta-analysis 73.5 versus about 40% with grade 3 for treatment-related adverse events. Here again, this is again a study, a meta-analysis from China, and comparing, and we can see that there's a benefit in the overall survival for the triple combination by adding the intraarterial HIAC therapy. And this was all retrospective and meta-analysis data, but now there are 3 ongoing trials, randomized control phase 3 trials, all looking at triple, or even in the case of this last one, quadruple therapy for these patients. And these are all studies in China, and whether this is applicable to our practice in Europe or practice in the US is an open question. But I think it's very important to keep this in mind, because as I showed from the I Am Brave post-hoc analysis, these are patients with very poor prognosis. So even with the 2026 update of BCLC, we can see that the stages were not really altered, and still any vascular involvement immediately becomes stage C. And the BCLC, if we look at it again, is what's known as a stage hierarchy approach. Everything is determined by which stage you're initially grouped into. The fact that it's lacking this granularity, in that we saw that there is a lower adherence in certain stages, has made other treatment algorithms rise up and get some attention, including this very interesting what's called multi-parametric therapeutic hierarchy from the Italian group, and specifically from the group in Padua. And as opposed to the stage hierarchy approach, this is a therapeutic hierarchy approach. And they say, in the end, while stage is important for prognosis, it might cause undertreatment for a lot of these patients. And as we saw from the studies, these are uptreated or upwards migration of treatment anyway. So let's do it a little differently. Let's have an ordinal therapeutic hierarchy. And this is from the most curative to the least curative therapy. And then for each of these, we have reasons to not use that therapy, with varying degrees of absolute contraindications versus things that are more or less important based on the number of X's here. This will help us decide how each patient receives the best curative or the most appropriate therapy. And this is really not done by strict stages, but rather by a multidisciplinary expert decision, which is really how we treat these patients in our multidisciplinary team. The most recent addition is also having a converse therapeutic hierarchy, where we were also looking at the chances of each of these therapies to converting this patient to curative therapy. So what is conversion therapy? This is an idea where we can take a tumor that is initially not eligible for curative therapy and make it eligible for such therapy. And the reason this is a little different than most oncological treatment algorithms is that usually once a patient is responding to therapy, especially with more advanced disease, we keep treating with that therapy and we won't really stop it. But here, what we should really be doing is very carefully thinking about our patients and deciding when the right point is to offer them conversion therapy, curative therapy, if they have responded well. And these are indeed the recommendations from the most recent EASL guidelines for patients who achieve downsizing or downstaging, both from local regional and systemic therapy, and they should be candidates for conversion therapy. Why it's important to talk about this, and this is, again, a study from Alessandro Vitale from the Padua group, and that is that we're not very good at this, apparently. And this is from an international consortium, 48 centers, where there was potential conversion therapy for 16 and 13% of patients who received systemic therapy, atezobev or lenvatinib. The actual conversion rates were quite low at 3%. So many of these patients were not offered conversion therapy. And again, if we look at those who were, the 3-year survival is quite phenomenal at 93% after getting systemic therapy. So we should really be thinking about this in our patients. This is already in the UNOS system. Patients can be downstaged into Milan as long as they adhere to these criteria of what's known as up to 8 based on their original tumor burden, and as long as their alpha-fetoprotein is not increasing, and if it was over 1,000 is now under 500, and we need to wait 3 months to give some washout of the systemic therapy. But there's clearly a path to even transplant these patients. And this is actually being looked at now in a prospective trial, the Talent Top, where patients, even with macrovascular invasion, who receive atezobev and then are found to have technically resectable tumors are then randomized to surgery versus atezobev, with the main outcome of time to treatment failure, but also secondary endpoints of overall survival and progression-free survival. And we can see that both of these, the time to treatment failure was positive. So this was a positive study thus far. And the overall survival data is looking interesting, but is still immature. So this is being now looked at, conversion therapy, in a prospective way. So to summarize, HCC remains a leading cause of cancer death in our patients, specifically in patients with cirrhosis, and has a poor overall survival rate of roughly 20% for 5 years. Intermediate stage is quite a heterogeneous group, and it requires individual tailored therapy. So perhaps we should be thinking about more flexible treatment algorithms and staging systems. Therapy for these patients includes, as you saw, a combination of local regional systemic therapies, and they really depend on tumor burden, liver function, and performance status, along with factors such as portal vein involvement. And combination therapy, while not endorsed yet, may benefit the patients who have excellent liver function, but a higher tumor burden, but we still have to see positive overall survival data to justify the additional toxicity. And with the efficacy of our new therapies, we should really be thinking about patients with the successful downstaging. We should be offering them conversion therapy in an appropriate and timely manner. And finally, this is a complex disease in complex patients, especially in the intermediate stage, but in other stages as well. And this requires multidisciplinary care, preferably by an expert multidisciplinary tumor board. Thank you for your attention, and I'm very happy to take questions.
Thank you, Dr. Lalazar. Wonderful lecture and a lot of information around the intermediate stage HCC treatment. And this field is evolving so much in the last several years with the advent of immunotherapy and the newer therapies as well. Mike, a couple of questions I will ask, and then I will let our audience think some questions and maybe put in the chat, and then we'll invite them one by one. And also I'll invite some of our moderators from around the world. So first thing is, how do we approach a patient with HCC in a child C, but low melt, and within maybe with an intermediate stage HCC?
Child C are usually excluded from trials. I think I'll divide it into several things. First of all, we have to think about the fact that some of the factors in child are affected by tumor burden. So if we have a patient with high tumor burden and we think that's affecting their albumin, bilirubin, perhaps they have portal vein tumor thrombus, which might be contributing to ascites, but these patients are otherwise fit with good performance, then we might consider treating them. And if we look at the trial data, we can see that there are always a certain percentage, usually under 10%, that somehow sneak in into the trial. But I think as we increase in the child score, even within child C, we have to remember that usually we're not helping these patients by treating them, because in essence, what's determining their prognosis is their liver disease and not their tumor. By and large, these are patients that should not be treated from an oncological perspective.
Thank you. And second, we have learned a lot about histotripsy as an evolving modality for bridging patients and managing these patients with HCC, although the data has been just evolving. But do you have any thoughts around including histotripsy in the management of HCC?
Yeah, I think I don't have any personal experience with that. I think these are all definitely interesting modality, and we'll have to see what the data shows. But I think that especially will be interesting if it can help us in patients where it becomes more challenging to do ablation, TACE, or TARE. So there's clearly an area where there's a need for more local regional therapy. And when we look at the hierarchical therapy algorithms, technical feasibility will cause us to go to a different stage. I have to say, in our older patient population, in our HCC clinic, we're observing patients that are upwards of 80 years old, and many will elect not to go for surgery. So local regional therapies are very important here as well.
Thank you so much. May I invite Dr. Dharmesh Kapoor from India? Dr. Kapoor?
Very fascinating talk, Dr. Lalazar. And you very rightly point out that the treatment has to be nuanced in the intermediate HCC. I think the literature suffers from the fact that the comparisons have not been very scientifically robust. You started off the discussion and conversation by talking about TACE versus TARE. So the Western world swears by TARE, and in the Eastern Hemisphere, they are very good with TACE. I think the jury is still out, because we would all concede that the TACE cost is less, but the detriment to liver function is much higher than TARE. So if there are lesions which can be either TACEd or TAREd by way of technical feasibility, that would be the true measure of what preserves the liver function and what can actually lead to a cure. In fact, if you read the Western literature, it tells you that the transplant-free survival is improved only by one loco-regional therapy, and that is TARE, because it does lead to a better tumor necrosis. So I think the literature is still a little fuzzy when it comes to comparison between techniques. My question to you is, what are your thoughts on using systemic therapy, say a TKI, pre-TACE or TARE? So you mentioned about the legacy trial, but one of the reasons why they also got such fantastic results was that the TACE procedure was preceded by the TKI. So what are your comments on that?
I think, and this is the way we're doing it, I think this should be done currently in the setting of clinical trials, if you have them. Again, in our patients with the rise of MASLD, and we have patients with non-cirrhotic HCC, those are the patients where if they have a higher tumor burden, we should be thinking about combining. If you look at the trial protocols, then this is definitely done in conjunction. The systemic therapy, be it TKI or ICI, is given in conjecture with the local regional therapy. And the idea here is to have the immunogenic tumor necrosis, induce a stronger immune reaction once the ICIs are on board. So I think sequencing probably would be the other way around, perhaps, or together. I think both from respect, TKIs and bevacizumab or other anti-VEGFs are working against the VEGF secreted and therefore inhibiting the neovascularization. So I would probably say together and after. With regards to giving that before, then I think the data for that is probably weaker. And I think I would probably elect to put these patients on clinical trials, most of which have chosen a different sequence.
Thank you.
If I may, Dr. Kapoor, your question, there was a slide that I didn't show, but I debated. Can you all still see my screen?
No, you got to share it if you want to.
So let me share again. And then I made this slide. I was deliberating whether to show it or not, but we can show it now. And this is exactly what you were saying. When you listen to these debates about TARE, it sometimes sounds like a couple trying to buy a sofa. Some are saying, yes, it has some advantages, more tolerable, better local control. In the setting of pre-transplant, they showed that there is a more tumor necrosis. And this is sort of Europe versus US. And then there's always the question of, does it improve survival? And I think these are on the left here, different reasons, potential reasons of why this is so different. The data is the same data, as you mentioned. And as I showed earlier, most of it is retrospective. We have very little prospective data. And some of it, definitely in Israel, and I'm understanding from you also in India, has to do with reimbursement and access. We have very strict reimbursement policies for TARE, which is far more expensive than TACE. So we're only allowed to do it, and they'll pay for it if there's portal vein thrombosis or TACE failure, whereas it's much more permissive in the US. So I think that's very relevant to this discussion. But also there's, as you mentioned, a different interpretation of the data from key trials.
Yep, completely agree.
Thank you so much. I see Dr. Ethan Weinberg is also here today. Dr. Weinberg, if you want to share your experience and thoughts, and your good friend, Dr. Lalazar, is also here.
I loved hearing this talk. This is one of the fields in hepatology where I feel like I'm more of an observer. I tend to refer out my HCC treatments to some of my colleagues at my local institution. So this was a learning experience for me. I don't have any questions. I thought it was great.
Thank you, Ethan. Thank you.
Dr. Raj Uchila from Australia, seen you after a while. Are you still on, Dr. Uchila? Or not?
Yes.
Yeah.
Sorry. Yeah, I'm on. Look, great, Dr. Lalazar. Thanks for that. Look, I just had one question, probably following up with the last question from Dr. Kapoor. Look, you mentioned TACE and systemic therapy, but my question is Y90 and systemic therapy. There's some literature, I think, with Druva and things like that, with synergistic effect of sequencing Y90 just before the immunotherapy. And we, in our own center, we use TARE a lot. Reimbursement somehow doesn't seem to be a big issue. I can't remember the last time we used TACE at all. And unfortunately, there have been some borderline cases where TARE was not possible because of a large shunt and things like that. And then they went on to get systemic. And remarkably, the shunt just closed with the use of Beva. And then we've been able to come back to Y90. And they've had good outcomes. So it could be just one-off case. But do you think there's a synergistic effect? And if so, what will be the best way to use it in these cases? So do Y90 and then immediately follow systemic therapy, or keep following up three monthly scans and if exhaust Y90 as an option and then move on to systemic therapy? She get my question.
Thank you. I think you really summarized the debate, so to speak. And I'll take two things from your question. I think the answer is, first of all, if you want to use the combination, then the right patients are those with excellent liver or as good as it can be. Those are the patients that we want to think about that. And on the flip side, a higher tumor burden. So that's a comment number one. Comment number two, I think this should be done in the setting of clinical trials. There are definitely some ongoing TARE trials with systemic therapy. Unfortunately, the TARE trials with TKIs failed, just like the TACE and TKI trials. But with immune checkpoint inhibitors, bevacizumab and others, and some TKIs, there's a pembrolizumab combination. So I think very interesting to see what those trials will show. But so I think to answer that, I think it should be done in the setting of a clinical trial because it's a situation where we don't have the answer for yet. And this will, of course, be in a setting where we can collect that data. I think to your question, though, there's definitely should be a synergistic effect of the same idea of cell death and then immune potentiation. But I think you had another comment, which is super interesting. And this really came up in the last EASL summit just a few months ago. And this is the fact that this is a tumor evolution, so to speak, with regards to therapy. And that is not only that you gave systemic therapy and then you were able to use TARE, but part of what's happening is when we use TACE and TARE, the tumor that previously didn't respond to systemic therapy might now respond to systemic therapy because of immune infiltration. So in essence, we have a tumor that's changing in response to local regional therapy. And the same atezo-bev that didn't work, or tremi-durva, or another combination, or ipi-nivo might work in the same tumor again. And some people are looking at biopsying these patients and looking at their cytotoxic T-cell infiltration to decide whether it's worthwhile to retry a therapy that's failed. So that's quite what you're describing, but in a reverse fashion. So I think that's a fascinating point.
Yeah. Okay. Thank you.
Thank you very much. May I invite Dr. Prasun Jalal from Baylor? Dr. Jalal, please.
Yeah, a fascinating talk and a difficult one because this is a very evolving and controversial area. Several comments rather than questions. Number one is BCLC. One of the biggest drawback has been it didn't, and as we all know, that HCC is complicated because it's a two disease. One is the tumor, the other one is underlying liver disease. And that's why what you are seeing, whether in all these modalities, even if there is a time to progression is longer, for example, in TARE, but the overall survival didn't change. I think one of the things it has done a little better because they incorporated ALB into it. So without that, there was nothing in BCLC to reflect underlying liver function. And child B and C is a little bit more extreme. So what I feel the main difference between East and West, they use resection a lot, even intermediate even with BP 3 or 4, they use resection a lot compared to what we do in the West. And I believe they get a reasonably good result. The controversy between TACE and TARE is like apple and oranges. I don't think we put same patients into the TACE versus TARE because in TACE is more limited disease we do, in TARE multifocal, more infiltrative disease. At least in our centers here, we use more TARE. So that's why even if there are some studies like TRESS study show TARE is better with the time TTP, but I believe that the selection and larger trial is still needed. And the other side is this immunotherapy, as you mentioned. Again, there are a lot of the pieces we don't always put into one classification. That's why the BCLC is not moving forward too much. And I feel that Europeans are more conservative than Americans. My question to you in terms of question is, do you feel, you kind of alluded to it, but do you feel that the systemic therapy based on biopsy, I would say their molecular classification or whatever you can say, in HCC, whether you use that neoadjuvant, adjuvant, whichever way it is, in combination, has any role to select whether the patient can go for immunotherapy or systemic therapy as a prerequisite, whether it's again neoadjuvant or adjuvant. What's your feeling about this tissue typing, which you do for cholangio? Oncology is moving a lot to this molecular classification, whether it's lung cancer, cholangio, but not so much in the HCC.
Thank you. I think I agree with pretty much everything you said. I think that, first of all, to relate to the first point, the staging systems from the time that I started treating patients with HCC and became familiar with the Barcelona Clinic staging system, it's apparent that the staging system is there, but we're not doing what it says quite often. And that is already somewhat troubling because in that case, it questions the validity. I think, first of all, it lacks granularity. I think many people were disappointed with the fact that it wasn't updated in 2026 to reflect, for example, granularity regarding portal vein thrombosis. There are quite a few trials already which are clearly looking at VP1, VP2 differently than VP4, with VP3 being somewhere in the middle, but that had to be addressed, I think. And there are other issues. And you're right. I think the Europeans, we are more rigid. But on the other hand, who wouldn't really want a resection if they have a small portal vein thrombosis in the subsegmental vein? And people are actually doing that. So it's really just this staging system needed to adapt. So I think that I fully agree with that point. And I think also your interpretation of why this is happening, I agree with that as well. I think it's a therapeutic cultural difference between US and Europe and East. Regarding the second part, could you remind me the question? The part where you said
Most to add the systemic therapy based on.
Yes, of course. Thank you. So I think that is definitely important. We don't have tools that are validated, robust tools, but I think we have to keep ourselves aware. Where would this be most important? To be most important where patients have a lot to lose and a lot to gain from systemic therapy. For example, if they have systemic autoimmune disease, which is not a complete contraindication, but we would really want to know what their chances are of success because we're afraid of autoimmune side effects. That would be one example. So I think this is evolving. We have two scores, the Crafty score and another score for predicting the response to systemic therapy based on CRP and alpha-fetoprotein. Those are being investigated, but are still not in the guidelines. We have the PNI score, albumin and lymphocyte count. And I think that the newest things is, as you said, histology. They've tried to simplify it. Different groups have different cells that they like, but usually these are different populations of T cells. And there's one group that just presented an abstract showing that they can use a very simple CD8 stain, including where those CD8 cells are, just surrounding the tumor or within the tumor. They have a score, and you could probably now design a trial to test that. So I think this is very interesting, evolving data. I don't think I wouldn't deny a patient systemic therapy if I biopsied them and they didn't have CD8 cells. I think that would be incorrect. That would be under-treating. But I think in the future, we could test this. Because we now have studies where we're giving mostly ipi-nivo prior to resection, these neoadjuvant trials that are going on, we're going to have data. And this is where this data is coming from. So we're going to have quite a bit of data regarding the correlation between pre-treatment biopsy and resection necrosis for response, complete pathological response or major pathological response. So we should have that data, and then perhaps we can base our decisions outside of trials on that score.
So in your patient which you presented, what did you choose? What did you do?
Wow, that's interesting. So this is a fascinating patient. This patient had a heart disease, which then became symptomatic. Her disease progressed quite a bit. Her alpha-fetoprotein went up to 1,200. We wanted to give her systemic therapy with tremelimumab and durvalumab because of a cardiovascular risk that we thought would make bevacizumab the wrong therapy for her. But this patient elected not to have treatment while she tried to get her aortic valve fixed. In the end, she was deemed non-operable, and they didn't want to redo percutaneous aortic valve replacement. So she had therapy for neither. She continues to come to clinic, and unbelievably, I saw her just a week ago, and her alpha fetoprotein now is 3, and she's due for imaging. I don't know if that'll reflect what's going on, but the patient as well. And this is 6 months after she had clearly progressive disease. So we wanted to give her systemic therapy. We thought that her disease was beyond TACE by lobar, and she needed systemic therapy, but by a miracle, she's doing well without therapy.
Not to prolong it, but how confident you were that really there's a 3 tumors? Because taste works, no question about it. Of course, probably I go more often here, but maybe sometimes I'll say that especially in decompensated cirrhotics, we are seeing a lot of patients. One radiologist is putting as HCC light at 5, the other radiologist saying, oh, there's no tumor burden there. So we'll have to be really, as another area in decompensated cirrhosis, I don't think we are doing a good justice. We need better imaging modalities. And coming back to your question about the tissue typing and about the HCC patients, this is one in an area definitely, again, unexplored because they're doing for other cancers. I strongly believe that, think about it, we know the mast cell patients, most likely the patient had mast cell too, the immunotherapy doesn't work. Probably 25-30% cases immunotherapy is helpful. So there's resistance. We are not choosing our patients right. And that's why probably the treatment, all the trials are not showing as good result as we expect. So there are many areas we need to work on, whether imaging or on the treatment side, including systemic therapy. But obviously, the difficulty is still, I feel, there is no good international consortium working together. Every country is like fragmented, similar to the ACLF, which is they're hoping that they're coming together slowly in the ACLF side. But HCC, we are really in different countries, different continents, working totally differently. I believe strongly that the International Society for Liver Transplant, HCC, in the ILTA or whatever, they all need to come together and work together in a concurrent way. But that's my take here.
Yeah, so a lot of, I think, super interesting comments. I'll start with the first one, the imaging for multiple tumors. So this patient had arterial phase hyperenhancing lesions, clearly, and new lesions, arterial hyperenhancement washout in a cirrhotic patient with previous HCC, extremely high pretest probability. I think this is a case where it's more clearly LIRADS 5. But to your point, I think the new guidelines address this by the use of different contrast agents for MRI. And what's really interesting there is that you can also get what you're looking for, the tissue typing. You'll have different characteristics. So you might have high-risk lesions based on your MRI that you might want to biopsy. So we've had a patient, for example, which had a low-grade lesion and a high-grade lesion. And this was perhaps if we would have used the MRI contrast agent, we would have been able to biopsy both before surgery. So I think that's a really good point. I think the trajectory of the patient is important. If you have new lesions appearing, increasing alpha fetoprotein, then this is, to your point, this patient probably has more lesions than what you're seeing. So that should also be factored in. With regards to tissue typing, this is pretty much everything that with regards to histology that was talked about in the last EASL summit. So I think that's coming, hopefully soon, to help us. Regarding fatty liver, I think that's interesting. Initially, after the I Am Brave, the subgroup analysis and the Nature paper on the lack of response with mast cell D, I think that's been refuted to some extent, where there's no real change between viral and mast cell D with regards to response. But I think you're right. These are different patients. And then we have a different problem. When you have hepatitis B, then you have liver disease. When you have mast cell D, you have whole organism disease with a sick heart and sick kidneys, et cetera, et cetera. So that might affect prognosis as well. With regards to your international consortia comment, I think that is really interesting, but I have an interesting take for you to consider. And that is, I think some of the differences in data that we're seeing have to do with different patient populations, For example, in Asia, they have about 30% of their patients that are non-cirrhotic. These are the HBV patients. So they have these phenomenal overall survival response. Part of it has to do with aggressive therapy. Part of it has to do with a very healthy liver, comparatively speaking. The other thing is that when you look at the difference between multi-center TARE trials or TASTE trials, as opposed to single institution trials, vast differences. And part of that has to do with local expertise. And I think that's actually real. And when you have local expertise, that will affect the tumor board decisions. It always really strong IR groups. So your point is very well taken, but I think it's also complicated by those different patients and different doctors.
That's great. No, thank you. Enjoyed it.
Thank you, Raj. Do you want to go back?
Yes, look, only if nobody else has a question. Look, I just had a question. Do you consider TARE and SBRT to be complementary modalities? As in, would you switch from one to the other if the response has been suboptimal initially? Not necessarily the same lesion, but say they recurred at a later time. Both radiation modalities.
Great question. We usually don't combine them. There's interesting data regarding using SBRT again. So you have, for example, this patient had partial response. We debated whether to irradiate her again, but the risk of hepatic decompensation goes up dramatically with the second radiation therapy. So I don't know whether there's similar data for the combination of TARE and EBRT, but I would be weary of that because the second radiation is not as well tolerated as the first. But there is data for combination local regional therapies, for example, combining TACE and ablation for larger tumors. And so, yes, different modalities. Yes, perhaps two radiation modalities I'd be worried about. I don't know. Are you aware of data specifically looking at that combo?
No, I suppose what I was trying to lead to was say at different time points, with the tumor biology dictate that a particular tumor wouldn't be responsive to radiation. Say they successfully tear as an SBRT at one point in time, small lesion, not resectable, but did not get resected, ablated, and they get SBRT and they got complete response or incomplete response. Then I suppose that was my question. I suppose you're getting it to that two radiation would hammer the liver, and so
Yeah, worry about toxicity, exactly.
Okay.
And back to your point that we are using SBRT a lot nowadays, as you all know that HCC is radiosensitive, and we are seeing that the imaging effect takes time. But even the patients who have been declined for TACE, because of maybe bilirubin borderline or something like that, although we do subselective and including Y90 in these patients, SBRT has been very well tolerated. So we should be thinking more and more. I'll look at the data because so far what I've seen, the data is very encouraging. Now, whether in combination, I don't think we can say that, and only individual expertise in local centers, but I don't think good data on that. Going back to histotripsy, Sanjay's question, Sanjay, if you see that Liver Hope trial, they don't use for more than 3 centimeter lesions, and recently they can expand up to 5 centimeter, but I don't think it's a new technology. We can say that we can use histotripsy in intermediate stage tumor at the moment. Probably we'll go with the smaller tumors where we can use ablation therapy, like any ablation, is radio frequency, whatever, rather than using in conjunction with or as alternative to TARE or TACE. Currently, unless we have more data, it's still a little early.
No, I agree with you. But the only reason I was bringing that question was in compared to TACE, TARE, and the SBRT, histotripsy does not apparently affect the bile duct, the pore and the vessels. So that may have an advantage as we go to higher grades of child stage, but I don't think we have enough data. That's why I was asking if there is any evidence already building around that, or maybe some trials around. That was the reason I was bringing it up, but I think certainly we don't have enough data to recommend it. Sure.
At the moment, we're using for patients who are supposed to go to ablation. So it's more as an alternative rather than doing anything more than that heroic. But we have to watch the space. Thank you.
Thank you. And then may I invite Dr. Benedict Maliakal?
Thank you.
Are you getting a noise here?
I don't know why
You may have two devices.
You probably have two devices. You have to switch one of them down.
Let me see. I don't know.
While you're waiting, I have a question. So what's the common etiology of HCC in Israel or Middle East, do you think?
We're still seeing the majority with HCV,
Huh.
with the definite troubling phenotype of post-SVR HCC. What led to the worry that was then again debunked, but still worry about having post-SVR inducing HCC. But I think these are just patients that are now living for many years with their cirrhotic liver, whereas before they would decompensate, and now they are just there for 10, 20 years and you get HCC. So that's a good portion. The other large population obviously is the mast cell D patients, and we're seeing a fair number of non-cirrhotic patients, which is, of course, making us very uneasy with regards to the screening. So that's a whole issue we didn't talk about. But in Israel, it's a pretty hot debate. We are pretty bad compared to Europe with obesity. We have a sizable mast cell D population, as can be expected. And these patients are usually coming in, they're 70 plus years old. And we don't even know they have cirrhosis. So their first presentation is with decompensated liver disease and HCC, and they really end up getting nothing. So we have a lot of work to do.
Are you seeing a lot of intrahepatic cholangios? Because some HCC and this cholangio, there's a big overlap, same etiology, literally.
Yeah. We are seeing cholangiocarcinoma. We're not seeing a lot of mixed tumors, just occasion, maybe one or two a year, but definitely a lot of cholangios.
Dr. Maliakal, you can go now. I actually removed I think you had two connections here. So you can go ahead now. Dr. Maliakal?
Muted now?
No, he's on mute.
I think there is
Sorry, while we wait. Sorry. Would that mean that you're worried about treating hepatitis C before treating the HCC?
So sequencing between hepatitis C and HCC therapy. Usually what we'll do, to put this into context, what are we trying to achieve? Usually these are older patients. The question of public health and infectivity, etc., is most of our HCV patients are patients that were infected during childhood, immunization, former Soviet Union, etc., and not IV drug abusers. From that respect, it's irrelevant treatment for public health reasons. Treating to recompensate the liver so that you can better treat HCC. So that's been looked at and doesn't seem to be an indication to treat. So what we're left with really is trying to do what will have the most important effect on the prognosis of the patient. And therefore, what we usually will do is if the patient is responding to the initial, as soon as we have response to the initial HCC therapy, then we'll treat hepatitis C. And that's clearly from a utility perspective, where there's no point in giving them therapy if they're decompensating and dying from cancer. It would just not make a difference.
Yeah. It sounds like you're not worried about the HCC getting out of hand without HCV treatment.
So that's what I was referring to, the early days of the direct antivirals. There was a sense that we might be inducing HCC, but I think there was a heated debate for about 5 years, but that's pretty much been laid aside for now. But we still see these patients, and I always worry whether it's related or not, but I remind myself that it's been looked at. I hope it's not true.
Dr. Maliakal, your question.
I hope I fixed the problem. The thing is, this is a very complicated field, but ultimately in the intermediate stage, the overall survival with all the manipulations does not seem to be all that. There's maybe very incremental change. So I think moving forward, I think we have to add something like Preston mentioned, molecular markers. We use immunotherapy, but we know that both cirrhosis and immunotherapy are impacted significantly by the gut microbiome, but we are not addressing that. So I think that needs to be addressed. And then, like person mentioned in MASLD, we may have to address STAT3 and insulin resistance issues and may have to incorporate that into the treatment. And things like whether circulating tumor DNA will give you some idea of whether we should do systemic therapy first before doing any local regional therapy, etc. These are things that may have to be thought about. And the last question is CAR T cell going to be a modality in HCC in the future?
Some really interesting points. Regarding the incremental improvement, I think we have to remember where we're coming from, and patients outside of transplant criteria only and outside of resection criteria only 10 years ago were really doomed. Within a year or so, sorafenib giving them really a minimal advantage with side effects, some improvement with lenvatinib, but quite rare to see patients with long-term survival. I think we have to acknowledge the fact that with the combination systemic therapies today, we're seeing things that we could never imagine before. And we have patients who are on these therapies long-term. We've had patients who are on atezobev for 4 or 5 years with extrahepatic disease. So quite incredible responses. So I think we're headed in a good direction. And these are patients.
But it's a hit or miss kind of situation. You can't predict. And I think the thing, by knowing more about the tumor and the patient, we may be able to predict better. And I don't know if the field is moving in that direction.
So I agree 100%. We would very much want to know if someone is responding beforehand. And there are quite a few prognostic techniques to determine whether or not you're going to respond to immunotherapy. Some of them are blood-based, some of them are histological, as we discussed earlier. I think that's definitely where the field is moving. Of course, the other really important thing is what we do in second line, because right now we have a second line problem. Some countries are not covering second line therapies. It's an issue in Israel, but we have an issue with the benefit from second line therapies. I think that's also important. So that means, and there are studies coming from Lovet's group in New York and others looking at the resistance mechanisms, beta-catenin signaling, etc., for immune checkpoint inhibitor resistance. So Wnt beta-catenin activation is associated with a lower response. So that is also, I hope, in the works. So everything you're saying, I think, is spot on and really important because it is completely hit or miss at this point. Agreed. Regarding circulating DNA, that has been tried and has not succeeded, to the best of my knowledge, yet in HCC. There were quite a few attempts, but it didn't pan out as in other tumors. But I think it's just a question perhaps of technology and looking at the right patients. I think it would be fascinating to see whether we could understand which patients with portal vein involvement are in fact metastatic patients because they have circulating tumor DNA, and which are those where are still local disease and it would make sense to resect them. So that would complement the VP or Cheng portal vein involvement classification. So that's really interesting, but hasn't worked out yet. Regarding CAR Ts, I'd say maybe, but the thing that's really more exciting now are the bispecific antibodies, and those are creating immune synapses and potentiating the immune therapy, making it both more specific and potentially more efficacious. There are quite a few trials on bispecifics for HCC, which are ongoing. We'll definitely look out for that data. I think the direction is, yes, the immune therapy, optimization, combination therapy. I showed the hepatic intraarterial pumped data from the East. Our patients with VP4 involvement are just dying. We've not seen any dramatic responses with those patients. So I think that's a group to focus on for more aggressive therapies as well.
Thank you. Thank you. And this is, I think we come to the end of this meeting. We already are already 9:30. First of all, I would like to really thank Dr. Lalazar because he's speaking from a war zone. And thankfully, this last 1.5 hours, we did not have the sirens coming out. Otherwise, you would have to move out to a bomb shelter or something. But to really, really appreciate you just keeping your promise, giving this talk, wonderful talk.
Thank you for breaking up. This is a great session and a fantastic question answer session.
Yeah. Again, thank you to our audience as well to coming and joining us, Saturday morning, especially from the east side. And I think it's already in Australia. It's probably midnight or beyond even. And so it's all coming out from all around the world. It's really wonderful. And we're looking forward to have another session in 2 weeks again. And plus, I would like all of you to explore our new redesigned website, the inetsys.com, where with Dr. Lalazar's permission, the talk as well as the PDF will be available to our members. So you explore, if you have missed this talk, especially, please come in and also explore the AI features. So about the talk that we have today, you can get the whole summary, as well as you can ask questions, specific questions about anything, and then the AI will pick up the answer what Dr. Lalazar has given the talk today. So please explore all those new features. And again, thank you everyone for joining. Looking forward for another exciting session in 2 weeks.
Thank you.
Thank you all very
Thank
much.
you.
Thank you for the invitation.
Sure, bye.